welcome everybody to the BIOS seminar. We're very honoured tonight to have Professor Alan Shewmon with us, who I'll introduce in a moment. Just to say, we're very much run on a shoestring, and any donations that anybody can make to the BIOS Centre to continue this kind of work and continue doing papers or conferences is very, very much welcome. So if anyone is able, then please go to our website. There's a link in the chat as well to donate, or even better, sign up for a direct debit if you're able. This will be very much appreciated by us and will allow us to continue in our work in some of these critical areas of medical ethics. So tonight we're very, very honoured to have Professor Alan Shewmon, who will be speaking to us on the topic of brain death and brain stem death, a critical update. He is the Emeritus Professor of Neurology and Paediatrics at the David Geffen School of Medicine at UCLA, Los Angeles, California. His main areas of academic interest are pediatric epilepsy, clinical neurophysiology, disorders of consciousness, and brain death. On topics related to brain death and disorders of consciousness, he has authored dozens of publications, served on national and international committees, and given numerous lectures at national and international levels. So, without further ado, Professor Shewmon.
Thank you very much, and it's a pleasure to join you across the ocean. Being in Boston, we're only 4 hours apart, so we could be neighbors almost. I'm going to give you an update on both sides of the ocean, the US brain death guidelines and the UK brain stem death guidelines, which were updated only recently in 2025. So on this side of the ocean, the update, well, we have to discuss what we're updating. So the first American Academy of Neurology guidelines were published in 1995, and they were updated in 2010 with this title, Evidence-Based Guideline Update, Determining Brain Death in Adults. The title is rather deceiving because when you read the article, it says that everything lacks sufficient evidence and that the guidelines are actually opinion-based and not evidence-based. On the pediatric side, guidelines for children were first published in 1987 and then updated in 2011. Most recently, the adult and pediatric guidelines were consolidated into this one grand guideline published in 2023 and endorsed by the American Academy of Neurology, American Academy of Pediatrics, the Child Neurology Society, and the Society for Critical Care Medicine. So that's the update I'll be talking about on the US side. On your side of the ocean, the update goes all the way back to 1976 with this publication of the Conference of Medical Royal Colleges entitled Diagnosis of Brain Death. Then 3 years later, we have this slightly updated version, Diagnosis of Death, not just brain death, but of death. Then fast forward to 2008, where the Conference of Medical Royal Colleges has been renamed the Academy of Medical Royal Colleges, and they published this code of practice for the diagnosis and confirmation of death. And that was updated just last year. So that update is what I'll be discussing. Now I'm going to organize this talk into 3 sections because we can discuss death on these 3 levels. First, the concept of death, then the criteria, and finally the tests that doctors employ to see whether the criterion is fulfilled. So first, the concept of death. Prior to the Harvard Committee's landmark report in 1968, which introduced the whole thing of diagnosing death in terms of brain function, the concept of death was fairly well standardized and accepted. On the philosophical and theological level, death was understood as the separation of the soul. And if the soul is understood as the form of the body in the Aristotelian Thomistic tradition, then that separation manifests itself through signs in the body. And the biological concept of death was, we could summarize as loss of anti-entropy. So all living things oppose the tendency of everything in the universe towards entropy, towards disorder. Living things, on the contrary, organize themselves. They develop from embryos into full adult creatures, and they resist the tendency of the environment to break them down and make them die. So it's this anti-entropy that is really the core of the biological concept of death. Now, in the United States, looking at the left side here, I mentioned the Harvard Committee introduced brain death as death in 1968, but they gave no concept whatsoever. It was a purely utilitarian stroke, and it took 13 years before a coherent concept was presented for what had become already a fait accompli, where neurological determination of death was already enshrined in many state laws concerning death. It was implemented in hospitals, yet there was no concept underlying it. In 1981, the US President's Commission proposed really the first plausible concept of death that brain death was supposed to instantiate, namely integrative unity of the body. And the claim was that the brain is the master integrator of the body. So without brain function, the body literally disintegrates and is dead. After that, especially in the late 90s, it became evident that that was not the case. And I published in 1998 an article which was a meta-analysis of long-standing survivors with the diagnosis of brain death. Survivors in the sense of bodily survival. And I collected over 170 such cases. And the presence of bodily integration was very obvious in these cases. So this was all reviewed by the President's Council on Bioethics in 2006. And they concluded that the integration rationale for brain death simply didn't work. But they tried to rescue brain death by proposing a different concept of death, namely what they called the vital work concept or mode of being concept, which is based on commerce with the environment, which the council limited to breathing and consciousness. So other forms of commerce with the environment didn't seem to matter to them. This concept really never took hold. So by the time of the 2023 American Academy of Neurology update, a good 50% of neurologists, neurosurgeons, and intensivists, at least in the United States and Canada, and I assume that this applies as well to other countries based on surveys. A good 50% of these specialists who deal with brain death all the time did not accept the integration rationale for brain death. In other words, they considered brain dead patients biologically alive, but nevertheless dead as persons. And I'll get to this personhood concept momentarily, but that is the opinion of about half. Some of them, the other half, some of them still maintain the integration rationale, and the rest of them are kind of confused about why brain death supposedly is death, and they can't really give you a coherent answer, or simply say that that's what the law says. Now, on the UK side, in 1976, brain death was not even equated with death explicitly, but it was simply a grounds for withdrawal of care because of a very poor prognosis. The main reason for their update in 1979 was to explicitly equate it with death. But the concept of death was that death is a biological process. And so to stipulate a moment of death anywhere along that process is arbitrary. Now, in the 1980s, Christopher Pallas, a famous neurologist in England, wrote a whole series of articles about brainstem death. And his concept of death was irreversible apneic unconsciousness. Apneic meaning without the capacity to breathe spontaneously. And he based this partly on scriptural references, referring to passages in the Bible where the breath of life is breathed into creatures by God and they become alive. Curiously, the Bible also refers to blood as containing the life, but since Pallas and everybody else wanted to have a concept of death that would apply to people without brain function but with circulation, the importance of circulating blood was just pushed aside and ignored. The Academy of Medical Royal Colleges in 2008, their concept was essentially the same as Pallas's, irreversible apneic unconsciousness. And in the update of 2025, they reiterate again that death is a process, not an event, and that to assign a time to it is essentially stipulative, doesn't correspond to anything in the biological reality. But significantly, they changed the word irreversible to permanent. And I'll have much more to say about that as we go along. Now, this is what I'd say most neurologists and intensivists and neurosurgeons think as the concept of death. It's loss of personhood. And they equate personhood with capacity for consciousness. And I think this is what really was at the basis of Pallas's concept. I think consciousness was much more important than breathing. And that's the same for for everybody who endorses brainstem death. This is most succinctly summarized by Baker and Shewmon, who are two Canadian intensivists. Sam Shewmon has been kind of the driving force for the Canadian guidelines of brain death over many years now. And this is the concept that underlies the Canadian, and I dare say the American as well, concept of death. The capacity for consciousness and self-awareness is uniquely synonymous with human life and personhood, and its absence is necessary and sufficient to identify that death has occurred. The capacity for consciousness and self-awareness is the only irreplaceable emergent phenomenon arising from physiologic function of the brain that is necessary and sufficient to define the life of a person. So we have come a long way since 1968. So here's the AMRC definition of death. While biologically death is a process, it is necessary to define a point in the process where death can be diagnosed and confirmed in an accurate and standardized, timely manner. So again, they're reiterating this process idea that goes all the way back to 1976. And they say it's necessary to define a point. So the stipulation of a point along that process is arbitrary, is necessarily arbitrary, but they're saying that it's necessary to do this for the sake of society and the practice of medicine. Death entails the loss of those essential characteristics which are necessary to the existence of a living human person. The definition of death should therefore be regarded as the permanent loss of the capacity for consciousness combined with permanent loss of the capacity to breathe. So consciousness and breathing are the only what they consider essential characteristics necessary to the existence of a human person. And note again the switch from irreversible to permanent. Now I'm going to move on from the concept to the criterion of death. Prior to 1968, the criterion of death was the irreversible loss of all vital functions, breathing, circulation, and responsiveness. How was irreversibility determined? It was determined by the wait, the death watch, and waiting for unmistakable signs of death, such as livor mortis, rigor mortis, putrefaction. Now, with the introduction of brain death, the United States in 1981, with the President's Commission, introduced a bifurcated criterion. So death could be diagnosed either by irreversible cessation of circulation and respiration or by irreversible cessation of all functions of the entire brain. And this bifurcated criterion became the model law called the Uniform Determination of Death Act, the model law for all 50 states. Some states retain their pre-1981 laws, but most have some version of this UDDA. Now, in the intervening years, with the publication of these adult and pediatric guidelines, they claimed to follow the legal definition. In other words, irreversible cessation of all functions of the entire brain. But, as we shall see, they actually did not. In the first few years of this decade, the discrepancy between the practice of brain death diagnosis and the law became extreme enough that it was felt that we needed to not align medical practice with the law, but align the law with medical practice. So there was an attempted revision of the Uniform Determination of Death Act by the Uniform Law Commission. In the end, there was no agreement on how to revise it, and the whole attempt was abandoned. Nevertheless, the American Academy of Neurology and the other 4 medical societies that authored the 2023 update did an end run around the Uniform Law Commission and published new guidelines with the updates that they had been lobbying for all along. The most important details of the update was the shift from the word irreversible cessation to permanent cessation of brain function, and the explicit exclusion of some brain functions. So the law says cessation of all functions of the entire brain, but the new update says hypothalamic function and autonomic functions and electrocortical functions just don't matter. Now, on the UK side of the ocean, there is no statutory law analogous to the American UDDA. Rather, there are medical codes for diagnosing death, and the courts respect those. Now, prior to the update, the criterion was irreversible cessation of all brainstem functions. And only 2 brainstem functions really mattered to correspond to the concept, namely consciousness, which is enabled by the upper brainstem, the ascending reticular activating system, and breathing, which is controlled by the lower brainstem. Now, what is the role of brainstem reflexes? Well, it's allegedly to guarantee the irreversibility of these 2 conceptually important brainstem functions. Now, the 2025 update changed the adjective irreversible to permanent cessation of all brain stem functions. Now, why was everybody so intent on changing irreversible to permanent, when traditionally understood death is not reversible, short of miracles? In the early days of brain death, the terms were used interchangeably. But starting in 1993, with the Pittsburgh Protocol for donation after circulatory death, there arose controversies over redefining irreversibility. And in 2010, James Burnett, one of the prominent neuroethicists in America, he proposed the term permanent to justify donation after circulatory death as fulfilling the dead donor rule. Because obviously, if you wait for 5 minutes after the heart stops, the patient is still potentially resuscitatable. So the heart has not stopped irreversibly. But if you then go ahead and extract organs, the heart has certainly stopped permanently. So for the sake of this form of donation, the term permanent was preferred over irreversibility in the context of circulatory criterion for death. Now, in 2020, with these the lobbying to revise the American UDDA, the proposal was to apply the term permanent to both circulatory and neurologic criteria. Now, people who are familiar with the brain death literature may say, well, this sounds very much like the semantic bifurcation that I have introduced back in 2010 with this publication at the bottom. And I proposed that so much of the intractability of the debates about brain death are due to treating univocally the word death, when actually people mean it in two different senses. And so they're talking past each other all the time without realizing it. So there's a metaphysical meaning of death, which I called de-animation, which is the loss of the separation of the soul. And biologically speaking, it's the loss of that anti-entropy that keeps the organism alive. And the cessation of that kind of function is irreversible. You cannot reverse the loss of anti-entropy.
Bother you? Have you lost your water? Yeah.
What was that? Somebody isn't muted. Then the other sense of the word death is what clinicians mean when they declare death in a hospital and they assign a time of death, and it goes on a death certificate, and that becomes the legal time of death, where wills go into effect and married people become widows and widowers, and so many other consequences from the time of death. Now, this is a real distinction, and nobody has ever pretended that clinical death was the moment of metaphysical death. To prove that, one need only look at the practice of Catholic priests in giving the last rites, where the manuals, the pastoral manuals instruct them to administer the sacrament to someone even after a declaration of death, or after apparent death, clinical death, up until the time when unmistakable signs of death, such as livor mortis, rigor mortis, etc., are present. So there are these two senses of death that really ought to be distinguished, but have not been in the literature. Now, by changing the adjective from irreversible to permanent in the medical criteria, we have some really serious problems. What I just explained about the semantic bifurcation corresponds to semantic univocity in these criteria. So all death for them is permanent and not necessarily irreversible. I proposed that the clinical death, the permanence, is a retrospective declaration, and it is timed to the onset of circulatory arrest. But with the new criteria, the timing of death is arbitrary. With donation after circulatory death, it's a prospective declaration after so many minutes of circulatory arrest. And with neurological declaration of death, it's even more arbitrary. With the distinction that I proposed, autoresuscitation would be impossible. But with the new criterion, autoresuscitation is unlikely, and permanence becomes a self-fulfilling prophecy. This is true not only with the circulatory, but also with the neurological definition. And I proposed that if we're going to adopt permanence as the clinical criterion, then we need to couple that with the revision of homicide laws, because to cause permanence by not intervening when there is a duty to intervene, or by causing irreversibility when spontaneous reversibility would have been possible, ought to be considered a form of homicide. But with the new criterion, there is no revision of homicide laws. So basically, everyone has always understood death as inherently irreversible. This is metaphysical death now. There's been this semantic dissonance of potentially reversible death when it's defined in terms of permanence, because there's a period of time when it is reversible but permanent. Decay, which is succumbing to entropy, is thermodynamically irreversible. The bottom line is that death with these updates is no longer a biological phenomenon, but a concept gerrymandered to serve transplantation. And the self-fulfilling prophecy is a big problem with the term permanent, because reversible circulatory arrest could be made permanent by not doing cardiopulmonary resuscitation on a full code patient, claiming that from the time of the arrest, there was permanent cessation of circulation. Therefore, the patient was already dead, and there's no obligation to try resuscitating a corpse. Also, one could start removing organs without any waiting period at all for autoresuscitation, on the grounds that cessation of circulation was indeed permanent, and therefore the dead donor rule was allegedly respected. This was actually done in the case of Busek, who waited only 75 seconds before removing hearts of infants after their hearts had spontaneously stopped. Now, in terms of brain function, reversible brain non-function could be made permanent by, in the context of DCD, could be made permanent by ligating the arteries that supply the brain. But even in the brain death context, the reversible brain non-function could be made permanent by not implementing neuroprotective measures that are otherwise available. Now, I should say in defense of the people who publish these guidelines that I don't think they intend for this last caveat to take place. In fact, in the prerequisites for diagnosing brain death, they emphasize the importance of excluding any reversible causes of brain non-function. And they emphasize the importance of doing everything you can for the good of the patient. Nevertheless, if you take the wording of the new criterion at face value, it does leave room for this kind of abuse. And although the drafters of these guidelines may not intend it now, who knows what will come of this in 10 years from now. I'm going to turn now to the level of tests. It is repeated like a mantra that brain death is a, quote, clinical diagnosis, meaning can be made at the bedside. Well, this is not quite true because the prerequisites require establishing an etiology for the brain non-function, which typically involves MRI scans and other diagnostic tests, and not just a bedside exam. There have to be these prerequisites, that there be a known etiology sufficient to cause irreversibility. And there again, there's this lack of coherence in the updates because they want to get rid of the term irreversibility in the criterion, but as a prerequisite, it's important to establish a cause of irreversibility. The prerequisites also must exclude mimics and confounders. Mimics such as peripheral muscle paralysis. Confounders such as high spinal cord transection, which causes paralysis of arms and legs, and inability to breathe. And there's a whole list of potential mimics and confounders. The one thing that I want to point out is that one mimic and confounder is never excluded, which is global ischemic penumbra. So the ischemic penumbra comes from the stroke field. When somebody suffers a stroke, there's a core of necrotic brain tissue, necrotic meaning essentially destroyed, and it's surrounded by an area of decreased blood flow, which is not enough to sustain function of that part of the brain, but is enough to maintain the viability of that part of the brain tissue. Now, the goal of stroke therapy is to salvage the ischemic penumbra. Now, applied to brain death, we're talking about a global decrease of blood flow to the brain. So necessarily, in the process of going from normal blood flow to zero blood flow in brain death, the blood flow has to pass through the range of ischemic penumbra, where there will be no brain function, but the brain is still viable. This entirely mimics the clinical condition of brain death. There will be coma, no brainstem reflexes, no spontaneous breathing. Nevertheless, it is entirely reversible. The problem is nobody ever tests for this because we don't even have a good way to test for it. And nobody knows how long it might last in going from normal blood flow to zero blood flow. How long can a patient be in that state of global ischemic penumbra? Nobody knows. And no doubt it varies from patient to patient. So there's an important mimicker and confounder that is never excluded. Now we move on to what's called the cardinal triad, which is the bedside exam of coma, lack of brainstem reflexes, or brainstem areflexia, and apnea. This triad needs to be sustained for a certain observation period. In the UK, the duration of the observation period is not specified. The new update merely requires a second set of evaluations by 2 physicians, but it doesn't say how long after the first set of evaluation this second set needs to be. The American Academy of Neurology for adults even has eliminated the second set of observations and says that a single observation suffices. The pediatric criteria require at least 12 hours between the 2 observations. On both sides of the ocean, ancillary tests such as blood flow tests or EEGs are optional by default. But if some part of the clinical exam cannot be accomplished or is ambiguous, then an ancillary test becomes mandatory. But in most cases, it's optional and is not performed. So let's look at this cardinal triad. In the United States, it's supposed to apply to all functions of the entire brain. And in the UK, it applies to all brainstem functions. So the cardinal triad, again, is coma, loss of brainstem reflexes, and cessation of spontaneous breathing, or apnea. Now, coma is defined as a sleep-like state with eyes closed. It's a state of unarousable unresponsiveness. apart from primitive reflexes. The problem with this is that it doesn't jive with the whole concept of death, even based on consciousness, because coma can be compatible with consciousness. The conflation of unresponsiveness with unconsciousness is a holdover from old-fashioned behaviorism. And we know now that there is this phenomenon which has been called cognitive motor dissociation, so that patients who seem to be in a vegetative state or comatose can be inwardly conscious. And those who recover afterwards report accurately things that they heard going on around them, including conversations of physicians with family members about their being unconscious or even dead. So there is at least a 20% false positive rate of diagnosing persistent vegetative state due to cognitive motor dissociation. And it's probably more than that. Because of the recognition that consciousness is compatible with coma, it's good practice for nurses and everybody around a patient to talk to the comatose patient, even though you don't get any feedback, but you have to behave as though they are aware. Here's a case in point. Zach Dunlap was a 21-year-old Oklahoman who in 2007 had a all-terrain vehicle accident, severe head trauma. He was transported to a regional trauma center in Texas. After the injury, 36 hours after the injury, he was diagnosed brain dead, which was confirmed by a blood flow test. And since he had signed up to be an organ donor, he was being prepared for organ harvesting when he withdrew to pain when his cousin, who was a nurse, stroked the sole of his foot hard with the blunt portion of a penknife. So the organ harvesting was called off. He went to rehab, and 48 days after his injury, he walked out of rehab, made a nearly complete recovery, and was interviewed on NBC's Dateline program. So I'm going to play you an interview that Dr. Paul Byrne did with Zach, just one portion of the interview where Zach describes his experience while comatose.
No trouble, sir. Thank you for coming.
Always told me he had his helmet with.
See it? Allow to her that she did.
Next thing I remember was laying in the hospital bed, not being able to move, breathe, couldn't do anything, on a ventilator, and I heard someone say, "I'm sorry, he's brain dead, he's passing away." And there's nothing I could do. You could just get mad. I couldn't do anything to assign at all, and just kind of let it go.
Did you want to do anything?
I tried to.
What was that?
Tried to scream, tried to move, and just got extremely angry.
Yes. So it had to be a very painful time for you.
Yes, sir.
Okay. So I think that's a rather powerful interview. The next item on the cardinal triad is loss of brainstem reflexes. Now, brainstem reflexes have nothing to do with either the biological or the personhood concepts of death. So to make it a requirement is really ad hoc. The reason for including them is that absence of brainstem reflexes allegedly guarantees unconsciousness and apnea and guarantees the irreversibility of the unconsciousness and apnea, which is all that the brainstem death idea cares about, but it doesn't really guarantee that. Why? Because, for example, if you have primary brainstem pathology and what is above is working relatively well, then it's kind of like if the electrical power to your house went out, all the lights go out. You know, there's nothing wrong with the lights, and there's nothing wrong with the electric circuitry in your house, but nothing is working. And if the power company can't fix the problem, and you bring in an external generator, then all the lights will come back on. So in principle, in such cases, if you stimulate the ascending reticular activating system above the lesion, you could wake up the patient. And they'd be severely disabled, of course, but they would recover consciousness. So this has always been a problem with the brainstem death criterion. Also, it's kind of ambiguous. Are we talking about loss of all brainstem reflexes? If so, none of the guidelines require testing all the brainstem reflexes, and especially autonomic reflexes are not tested at all. So they require testing some brainstem reflexes, but the set that is specified in the guidelines is really kind of arbitrary. And there's a lack of evidence that if that particular set is fulfilled, then necessarily all brainstem reflexes are absent. We'll move on to apnea. So in the medical literature on this side of the ocean, there have been two debates in the journal Chest about consent for apnea testing. And back in 2017, there was this debate between Ariane Lewis and David Greer on the one hand, who represent the American Academy of Neurology, and Robert Trug and Robert Tasker on the other hand, insisting that there should be consent. Now in 2022, there was a repeat debate in the same journal between myself and Thaddeus Mason Pope. And obviously I'm going to give you my side of the debate. So apnea testing is almost always confounded. That's the first problem. Remember that as a prerequisite, we have to rule out confounders. But in the process of brain herniation, the upper cervical cord is often damaged just by the pathophysiological process. that damage is never diagnosed. When they talk about ruling out high cervical cord damage, they're talking about when the primary etiology is trauma to the head or neck. But this kind of intrinsic cord damage due to the herniation process is never ruled out, and it is a confounder for apnea testing, because if there's high cervical cord damage, then even if the brain stem is intact, one cannot breathe. Also, hypothyroidism and hypoadrenalism are common endocrine abnormalities in brain death, and they can suppress the respiratory drive. So the apnea test, first of all, is almost always confounded to begin with. Second, it does not adequately test for apnea. And I don't have time to go into details of carbon dioxide thresholds, but basically the threshold that is specified in all the guidelines is simply too low. And there have been cases reported of patients who met that threshold, but who breathed later on their own afterwards. So it's not an adequate test for apnea, nor does it test for hypoxic drive. And the hyperoxygenation that's given at the beginning of the test even suppresses the hypoxic drive. So the apnea test does not test adequately for apnea. Moreover, if the patient is not already brain dead, the apnea test is potentially harmful because the excess carbon dioxide, acidosis, and hyperoxia are contraindicated in severe brain injury. There's a risk of multiple systemic complications, especially hypotension. And the most important, which nobody ever talks about, is the risk of converting global ischemic penumbra into global necrosis of the brain. In other words, causing the brain death that it allegedly is helping to diagnose. Apnea testing has no benefit to the patient whatsoever. And ironically, all the guidelines allow for brain death to be diagnosed even without apnea testing. So, for example, if apnea testing is medically contraindicated or has to be aborted in the middle, the guidelines allow for brain death to be diagnosed by including an ancillary test. So, at a conference, I asked one of the authors of the US guidelines if brain death can be diagnosed without apnea testing, and since apnea testing carries substantial risks, why is it required as one of the cardinal triad components? And he was taken aback by the question and really had no answer. Said he'd have to think about it. Now, these tests of death, these are the guidelines, the 2025 UK guideline and the 2023 US guideline. All the guidelines, all through brain death history, have claimed to have certainty, that there are no false positive diagnoses of brain death using the guidelines. These claims, I think, need to be taken with a grain of salt because there has been a multiplicity of protocols for diagnosing brain death, and They differ across time, across the years, and across space from one country to another. More tellingly, the guidelines have undergone constant improvements. And the current updates claim to be improvements over their predecessors. Doesn't that imply that the predecessors' claim of certainty was unfounded? I think it does. And doesn't that suggest that the next iteration of updates 10 years from now is going to imply that the current guidelines claims of certainty are unfounded? Specifically, the specifying of details of apnea testing in the more recent guidelines certainly implies that the older guidelines, which did not specify how to do apnea testing, they allowed false positive diagnoses. The updated guidelines recommend, if you're going to do a radionuclide scan, using a lipophilic tracer rather than a lipophobic tracer, which is commonly used in hospitals because it's cheaper and more available. But this preference for lipophilic tracers was not mentioned in any of the earlier guidelines. So there's another improvement which implies that the earlier guidelines did not have the certainty that was claimed. And the current guidelines do carve out a special case for primary posterior fossa pathology, whereas the older guidelines did not carve out that kind of a case. So there are these kinds of improvements that really do imply that the early claims of certainty were unfounded. And I would say that the present claims of certainty are just as much unfounded, because there is a lack of evidence that these guidelines diagnose the criterion that they allegedly diagnose. And we've already seen that the criterion doesn't even correspond properly to a concept of death. So it's a big mess. The American Academy of Neurology has constantly claimed that there has never been a false case of diagnosis if the guidelines are rigorously followed. This is simply not true. Here's a whole list of published cases where the guidelines were followed, yet some brain function returned. And excuse me, I have to turn off this phone. Back in 2021, when the Uniform Law Commission was considering revising the Uniform Determination of Death Act, the cases that I showed on the previous slide are discussed in detail. So if you want to look at those cases, I refer you to this publication in Journal of Medicine and Philosophy, May 14th, 2021. And this statement was endorsed by 107 experts in medicine, bioethics, philosophy, and law, spanning a wide variety of perspectives. And I'm happy to say that two from the BIOS Center were signatories on this, Anthony McCarthy and Helen Watt. I would also refer you to this website, www.respectforhumanlife.com, which is kept by Heidi Klessig, who is a retired anesthesiologist and expert in brain death. And she has collected testimonials from people who survived diagnosis of brain death and recovered enough to tell about it. Now, some of these were probably not diagnosed according to rigorous following of the guidelines. Nevertheless, they do illustrate the phenomenon of covert consciousness or cognitive motor dissociation. People who were aware of what's going on around them, even though they appear comatose. And here's one a news article from the Telegraph about a Swedish stroke patient who hears doctors discuss removing his organs. And then he wakes up and tells about it. Now, what does this have to do with brain death? Well, you might be surprised that even in this millennium, Edgar Allan Poe's horror stories still sometimes occur in real life. So here's a woman who was in her coffin at a wake in South America, and she started knocking on the coffin, and they opened it up, and she was breathing and quite alive. Here's a man who was about to be embalmed, and he was discovered to be alive inside a body bag in the funeral home. Here's a Thai woman found alive in a coffin before temple cremation. So I show these because if it's difficult to diagnose circulatory-based death, criterion for death, all the more so should it be difficult to diagnose it neurologically. Now, what is an acceptable false positive rate for a declaration of death? Well, there isn't any acceptable rate. It's 0. And I could give you many, many more quotes, but these suffice to make the point. The criteria that physicians use in determining that death has occurred should, number 1, eliminate errors in classifying a living individual as dead, and 2, allow as few errors as possible in classifying a dead body as alive. The President's Commission also said that medical experts testified to the Commission that the risk of mistake in a competently performed brain death examination was infinitesimal. And we know that certainly was not true. So I could give you more quotations of this, but you get the idea. Now, how do we know what the probability of a misdiagnosis is? So back in 1987, I published a study in Statistics in Medicine, which did that calculation. And what I came up with is if you have N patients who meet a criterion and all of them fulfill, all of them have no return of brain function, then the probability of a false positive diagnosis is 1 over N plus 2. So to get infinitesimal out of that fraction, you have to have such an enormous study that it can't possibly be done. The same kind of analysis was done by others using different mathematical method, but coming up with essentially the same order of magnitude, a fraction over n. So given all of this, where does it leave us? We do not know that people who fulfill the diagnostic guidelines actually fulfill the criterion of death. And if you believe, as I do, that the criterion of death does not correspond to a valid concept of death, then we're in really big moral trouble. In 2024, a colleague of mine, Joseph Eble, published this article, The Moral Uncertainty of Brain Death. And now we're talking not about physical certainty, but moral certainty of acting upon the diagnosis of death. In particular, the removal of vital organs. And he concluded that we definitely have moral uncertainty that anyone diagnosed brain death is in fact dead. Well, where do we go from here? Well, it's now kind of at the level of the grassroots. This is not going to change top down. It's going to change bottom up. And there are a number of initiatives by people at the grassroots who are giving lectures, publishing articles, and making podcasts, and trying to make the public aware of these problems. There's my colleague Eble again with two other colleagues of his that published this statement, Catholics United on Brain Death and Organ Donation, a call to action. And in this call to action, they lay out a number of very concrete steps, but it all has to do with not agreeing to be an organ donor because there's no guarantee that you're going to actually be dead at the time of organ harvesting. And basically spreading the word about this. So I hope that this presentation will also help to spread the word. And thanks to the BIOS Center for all the good work that it is doing.
Well, thank you. Thank you very much indeed, Professor Shewmon, for an extremely interesting, alarming, and rich talk. I would like now to open up, if you have time, for some questions. If people could either indicate electronically with the symbol, or if they just unmute and wave their hand, I'll try and see you. If you don't want to do that, you can also use the chat at the bottom to type a question, and I'll read it out if you'd rather do it that way. So is there anybody who would like, okay, so Tony Sard, if you could unmute and fire away.
Thank you, Professor Shewmon. I'm a neurology fellow over here in the UK, and I read your papers about 10 years ago and found them extremely interesting and influential. So thank you very much for that talk. I have two questions, if I may. The first one, perhaps you answered it towards the end of your talk there. In your opinion, is there any ethical form of organ donation after death? And the second question is about your concept of global ischemic penumbra. It's an interesting concept. Is there any evidence that it is a clinical reality rather than just a concept? Thank you.
Sure. Thank you for both of those questions. Regarding the first, I already forgot what the first was. Would you repeat it?
Sorry, it's bad manners to ask two questions in a row. The first question is, in your opinion, is there any ethical form of organ donation after?
Yes. Yeah. So we need to distinguish between organ donation and tissue donation. So tissues such as skin, bones, corneas, and so on can survive for long periods of time without oxygen or blood flow. And there's certainly no problem donating tissue after death in the traditional sense. There's also no problem, no ethical problem donating organs or parts of organs that do not significantly harm the health or risk the health of the donor, such as a single kidney or a lobe of a liver or bone marrow. When we're talking about unpaired vital organs, like the heart or the intestines, or paired organs that you are talking about taking both of, like the lungs or both kidneys, then we'd have to say that those organs, to be viable for the recipient, need to come from an alive donor. And so the process of removing those organs is going to kill the donor. And it sounds like a hard thing to say, but it's just the way it is. So I think that the solution for people with failure of vital organs is in the future. It's going to be artificial organs. It's going to be organs grown from stem cells. It's going to be perhaps xenotransplantation. And I would dare say that the fallacy of brain death over these past 50 years has set back research in these alternative means of salvaging patients with organ failure. So I think that answers your first question. The second, is there any evidence that global ischemic penumbra, in fact, is clinically relevant? And the evidence, of course, has to be indirect, because hardly ever do we measure the blood flow in all parts of the brain in somebody who is being diagnosed as brain dead or brainstem dead. So the indirect evidence is really in these cases that recovered consciousness to tell us about it, like Zach Dunlap. I think such cases attest to his having been in global ischemic penumbra for at least parts of his brain in ischemic penumbra, so that he was unable to respond, but perhaps not the entire brain, so that he was still conscious. I think with respect to apnea testing, there is a paper reporting continuous EEG monitoring during apnea testing. And during the apnea testing, the EEG went from present activity to slower activity, meaning that the brain was being made more ischemic by the apnea test. So I think that indirect evidence such as these do attest to the clinical reality of global ischemic penumbra. I think Geffen math is a great case that demonstrates that. She was a teenager whose brain death was diagnosed by 4 flat EEGs and a radionuclide test that showed no blood flow. And of course, meeting all the clinical criteria. She survived 4.5 years after the diagnosis of brain death, most of which was in her mother's apartment. And starting a few months after the diagnosis, she began menstruation. And a few months after that, she began responding, making very minimal motor movements to commands. So I think clearly that radionuclide test, which was interpreted as showing no blood flow, was really showing a lack of evidence of blood flow when there was actually some low amount of blood flow that the test couldn't detect, which was enough to keep some of her brain viable, that with the passage of time, it recovered some minimal function, which she demonstrated. So I think she's another indirect example that supports the relevance of global ischemic penumbra.
Thank you. I'll come to the chat soon, but Peter Colosi, if you could unmute.
Okay. Thank you, Anthony, for the event. And thank you, Dr. Shewmon, for that great talk. And it's nice to see you. We've written to each other a lot over the years, but I don't think we've ever met in person. So my question is a philosophical one, and it's maybe just to hear your response to it. And I'm going to ask one question, but I'm going to pose it in 2 ways based on 2 separate parts of your talk. The first way I'm going to pose it is to say, do you agree with the premise that consciousness and self-awareness are emergent properties of physiological brain processes? That's the first way I'm going to pose the question. And then the second way is, later in the talk, you said that consciousness is enabled by the upper brainstem, or if that's not working, by in your analogy, the generator that can get the upper brain going again. I guess I'm asking, what do you mean by the term enabled? Is it just the physical brain processes that give rise to consciousness? It's really a question about the nature of the soul, but I'll just leave it. Does that give you enough to respond?
Right. And I think what you're getting at is how much credence to give to near-death experiences. So if you take near-death experiences seriously at face value, then there are documented cases with 0 brain function, yet these people afterwards report experiences that they had while their brain wasn't functioning. So they were clearly conscious during the period of brain non-function. We don't have time to go into the critique
Right.
of near-death experiences, but I tend to accept the veridical near-death experiences as pretty convincing. So I would have to say that under ordinary circumstances, yes, the brain enables consciousness, but there's a spiritual aspect to consciousness that transcends the brain.
Thank you.
That's what I would have to say.
Thank you.
Okay, just quickly, there's something in the chat, as well as the donate button, which again, I encourage you to donate to us if you like our output. There is a reference to a paper, and there's also a question from Patrick, who has asked, could you please comment on using MRA or CTA to register complete lack of cerebral circulation?
Sure. These are newer tests of brain blood flow that have yet to be validated. So, in fact, all of the tests of brain blood flow have not been validated as being able to distinguish between ischemic penumbra level flow and no flow in all parts of the brain. So until these newer tests can be validated to do that, then they have to be considered still with a question mark of uncertainty about them.
Thank you. David Oderberg, if you could unmute.
Yep. Thank you very much, Alan, for a really, really informative talk and a great overview. I just had a thought, how did it happen that issues concerning death in the medical context were hijacked by neurologists, by the neurology profession? It's almost as though it's a reflex of people, whether, bioethicists, physicians, philosophers, generally speaking, to think that, right, we need to look at, what are the neurologists saying? And the neurologists have kind of arrogated to themselves, as it were, the prime position in the pack to determine what counts as death. And that's always struck me, well, not always, but in, recently, since I've been kind of working and thinking about this issue, struck me as kind of really bizarre. That one way to maybe push back against this from a practical point of view is to advocate for other professions to be equally involved, other disciplines to be equally involved. Physiology, I would the first piece, and I know there's an American Association of Physiology, I'd probably go to them first. Physiology, cardiology, neurology, all of them, particularly the ones that are concerned with kind of more holistic and system-wide kind of aspects of human functioning, should have an equal role, completely equal role in getting together and forming, judgments about or evaluations of various criteria of death with no particular kind of bias, as it were, towards neurology. So how did that happen that neurologists got hold of it and they're the ones who kind of lead the pack?
I can tell you how it happened.
Mm.
We have to take the history clock back before 1968, because the whole idea of brain death did not start with neurologists. It started with transplant people. So in 1966, there was a symposium on transplantation sponsored by the SIBA Foundation. And there was a raging debate about whether organs could be taken from patients diagnosed as brain dead, and whether brain death was really death. And the big advocates for a neurological definition of death were not neurologists, they were transplant surgeons. And the very first one, Guy Alexandre from Belgium, he was transplanting kidneys from donors that he himself declared dead on the basis of brain function. Not neurologists. So the Harvard committee did have one or two neurologists on it, but it also was chaired by an anesthesiologist, and it had a couple of transplant people on it. And that Harvard committee was essentially formed for the purpose of redefining death for utilitarian purposes. Afterwards, I think neurologists got on board because all physicians got on board. We want to save patients with organ failure, and here's a pool of viable organs that could save them. So that's how it all started.
Okay, thank you. We have a comment from Raina in the chat. So unless Raina wants to ask it, I'll just read the comment. Professor Shewmon's explanations appear reasonable and are likely to make many listeners without experience in this area to follow his conclusion that brainstem death as diagnosis not being expedient. Problem: his talk is detached from reality. There is no case where any patient correctly, ! Diagnosed with brainstem death later regained consciousness. Professor Shewmon should look at the brain death protocols in the patient's file, and he would find inaccuracies in following the protocol. As a practitioner, I'm telling you, you don't do brain stem testing on any patient without knowing, based on clinical assessment, that the patient is indeed brain dead. This does not mean I want to tell others, including relatives, how to define deaths, but it is not helpful to circulate false information as Professor Shewmon effectively does. I am not saying what I'm saying in order to foment organ donation. Okay, well, that's a fairly general comment, but I don't, if you want to respond to that.
There are very few cases, and I would say Jahai McMath is the only one I know of, where a absolutely watertight fulfillment of the guidelines had recovery of consciousness afterwards. The cases where I was talking about recovering consciousness, Zach Dunlap was questionably following the guidelines because there is debate on whether his radionuclide scan was interpreted properly or not. The other cases of recovery of brain function that I listed were not of consciousness, but were of some brain function. And that's a big difference. So recovery of any brain function after a competent diagnosis of brain death is a counterexample. And there are published counterexamples. So I had one myself, a small child who was run over by a car. And he had all the pediatric criteria met, but an apnea test had to be aborted because he became hypotensive during it. So he had a radionuclide scan. And the radionuclide scan showed no blood flow. So he was declared brain dead. Parents elected to withdraw care and not proceed with organ donation. 3 minutes later, he started breathing. So he was reattached to the ventilator. And then there was this long discussion with the parents, who now were not trusting the medical people at all. Finally, they agreed to withdraw care. And the next time, the patient did not breathe, and he passed away. But that patient was not dead at the time the brain death diagnosis was fulfilled. After 2 clinical exams and an ancillary test supplying for an apnea test that was incomplete.
Okay, thank you. And also, Heidi Klessing has added in the chat, if anyone wants to look, in case of Jahi McMath. And there is a link provided to the review of Jahi's medical records, I think in support of a brain dead diagnosis, which was not actual death. Tony Sard.
Yes, thank you. This is somewhat in response to David Oderberg as well. As a neurologist here in the UK, we're very rarely involved in the diagnosis of brain death. It's entirely holed away in the intensive care department. We are asked to prognosticate about brain injury in patients who don't meet criteria. And we feel a bit co-opted under those circumstances. But just to go to the comment, I mean, it strikes me that if the test is so reliable and so certain, then it doesn't need to be done. So in response to the commenter who says he would only do the test in someone whom he's certain they are dead, I mean, it's totally circular. So I'm very persuaded from Professor Shewmon's talk that the tests are unreliable, the concepts which they are supposed to be testing are unreliable, and of course the theory underlying it all is also unreliable. So I've always found this quite alarming and unsatisfactory, especially as a neurologist, where I know the limitations of brainstem testing and the absence of reflexes and all the potential confounders. So yes, I think if neurologists were perhaps more involved, if that's not too arrogant, David, forgive me, then perhaps we might be a little better off. My concern is that neurologists are not involved enough, and people are making decisions about the brain without really knowing how the brain works.
Yeah, but I wasn't talking about what goes on in the hospital ward. I was talking about more panel definitions at more high level, kind of academic level. So I'm thinking about the clinical boards and government committees and that sort of stuff, rather than whether the neurologists are involved more on the ground floor, as it were.
Okay, well, thank you very much for all of these comments. Are there any last questions or comments? If I can just ask a very quick one, I hope it's not too left field, but I've noticed in the literature there are certain people who accept much of what you're saying, but have now started to propose. So they do not think that the tests for brain death are good tests for actual death. But they have a certain people, and there was an article in the Journal of Medical Ethics recently, which is saying that we should get rid of the dead donor rule because somebody should be allowed to, as it were, sacrificially offer a vital organ, and that could be a meritorious act that should not be precluded. And I just wondered if you're aware of this development and what your response might be to it.
Well, Robert Trug has been saying that kind of thing for some years.
Right.
So this is not a question for a neurologist. It's a question that I would bounce back to you as a bioethicist. So, and to David Oderberg and all the other philosophers and ethicists to discuss deontology versus utilitarianism and consequentialism and all of that. So I will defer that to you.
Good. Okay. Well, I myself and Helen Watt have written a paper on this actually some time ago. So coming out against, if anyone's interested. But just to say that that is a debate that slightly surprised me, that bubbling up. I mean, perhaps it's a recognition of your work, though, that people are now, as it were, making that kind of proposal, as it were, even whilst accepting what you're saying, as it were. Maria McKinnon, if you could unmute.
Yeah, thank you for an excellent lecture. You mentioned how the brain death criteria have been evolving. Has the direction of evolution been in what one way? Has it always been to make it possible to diagnose more patients as with brain death, or has it been also sometimes making the criteria stricter? That's one of my questions. And have you come across situations where in clinical settings, countries potentially where they've reined back on liberal use of brain death criteria to enable organ harvesting?
Regarding the second question, I'm not aware of such countries. Regarding the first question, I think the evolution of the guidelines has gone in both directions. So a lot of the changes have been intended to reduce the number of false negative diagnoses. In other words, declaring a dead person alive. So the reduction in observation period, for example. So the Harvard criteria started out with 24 hours. The American Academy of Neurology reduced that down to 6 hours. And now they've reduced it down to nothing. So that's in the direction of making more diagnoses possible, presumably while not increasing the number of false diagnoses. The Academy of Neurology initially had 2 tests, and then they reduced that down to 1 test. So again, that's in order to expedite organ harvesting, essentially. So there have been changes allegedly to reduce the false negative diagnoses without increasing the false positives. But in fact, some of these do increase the false positives. And in my talk, I mentioned some evolutions that tightened up the guidelines to reduce false positives, implying that the earlier predecessors were too loose. So it really is a complex evolution that has gone in both directions.
And I think we had a question from Kiran Jani, if you could unmute.
Right. Hello, everybody. Professor Shewmon, excellent talk. Now, I'm going to go away with a lot of food to digest for the next year or so. My background is as a retired anaesthetist, but during my senior training and for about 5 years as a consultant, which as a partial intensivist, I must have contributed to about 20 sets of testing by the criteria as existed then, and perhaps half of those sooner than later contributing to organ donation. So that's the background. I have been since 1990, yes, or slightly earlier, been carrying and registered with the British transplant organization to say, yes, should I be in that situation, I'm willing to donate as long as the criteria follow, yes? But I need to talk to a very good friend of mine who's the head of the organ donation program and chair of the clinical ethics service in the Liverpool area. So I will be seeing him in about 3 months' time, and face to face. And I've invited him to this talk, but I think I'm sure it'll dip into the YouTube video that's coming up. So it'll be interesting to see how where the British thought stands and where it's going.
Mhm. Thank you.
Thank you.
Okay, well, I think that's it. Well, thank you very much, everybody who's attended, and obviously a lot of people with great interest in this topic. And thank you very much indeed, Professor Shewmon, for extremely a thorough and invigorating talk. And as you say, as Kieran just said, giving us a great deal of food for thought for a very long time. So thank you all for coming. We're at the Bio Centre, of course, want to carry on putting on these things. So please do, if you can, think about giving us a donation. But we'll keep you in touch for future talks. And thank you once more for Professor Shewmon for your time and your virtual
Thank you.
and thank you very much. And we shall keep you informed. And we will make available the YouTube video of this talk and discussion in the coming days. Thank you very much.
Thank
Thanks,
you.
Alan. Thank you so much.
Mhm.